Alterations in elimination, gastrointestinal, pathophysiology and management. The digestive tract consists of numerous parts of our body. It starts off with the mouth, and this is where mastication, chewing, occurs. Food containing starch will begin to undergo partial digestion in the mouth due to the salivary amylase. Food will then pass down through the esophagus. The location will begin at the pharynx and it goes all the way to the stomach opening. Muscle tissue will surround the esophagus, and peristalsis is the way it moves down through the esophagus. Peristalsis is going to be that wave-like motion that kind of propels the food to the stomach. The upper esophageal sphincter is going to prevent air from entering the esophagus and the stomach, and the lower esophageal sphincter is going to be what prevents gastric contents from entering the esophagus. In other words, once it goes through into the stomach, it's not supposed to come back into the esophagus. Then food moves from the esophagus into the stomach, and it will temporarily hold ingested foods and then begin to prepare it into a semi-liquid form called chyme. The pyloric sphincter is located between the stomach and the small intestine. Gastric secretions are going to help break that food down into chyme, and the emptying time will depend on how much food there is and the composition of the food that has been ingested. The small intestine is where the food goes next. It's about 23 feet long, give or take just a little bit, and there's 3 different portions. The primary function of the small intestine is to absorb nutrition. So we have the duodenum. This is where bile and pancreatic enzymes will enter into the small intestine to break down fats, carbohydrates, and protein. The chyme is then propelled through the small intestine with that peristaltic movement. The next portion of the small intestine is the jejunum, and then we have the ileum. There is an ileocecal valve that separates the ileum and the cecum and controls the flow of intestinal contents. It also helps prevent the reflux of feces into the small intestine. So basically, the small intestine, we're absorbing the food. We are not developing the feces, or this is not where the waste material is. That's going to happen in the large intestine. The large intestine is about 4 to 5 feet long, and its primary function is to receive that waste from the small intestine. It's going to start absorbing water, some electrolytes, and bile acids, and then it's going to propel it through the intestine, the large intestine, to eventually eliminate it. So it is made up of the cecum and the colon. We have the ascending, the transverse, the descending, and the sigmoid. So the ascending starts on the right side of the abdomen. The transverse is where it goes across. Then descending will be on the left side of the abdomen. And then the sigmoid is going to be the lower portion, the rectum, and then the anal canal. That appendix is going to be a blind tube at the tip of the cecum. So again, this will be on the right side. It has no known function in the human. When fecal mass reaches the rectum, it's going to be held there by contraction of that anal sphincter until distension occurs, and that will then stimulate the urge to defecate. Accessory structures of the gastrointestinal system include the peritoneum. And this is going to be what basically lines the abdominal cavity. It kind of holds all of those abdominal organs. We do have three accessory digestive organs. This includes the liver, which is a glandular organ. It is going to be what forms the bile. It processes vitamins, proteins, fats, and carbohydrates. It stores glycogen. It also helps with coagulation and metabolizes chemicals, bacteria, and foreign matter, and helps form antibodies and immunizing substances. Then we have the gallbladder, which its main function is to store bile. Bile will then be released when food, especially fats, is digested. And then finally, we have the pancreas. The pancreas is an exocrine and an endocrine gland. When we're talking exo, that means it is outside, and endo means it's inside. The pancreas produces enzymes to digest fats, proteins, and carbohydrates, in addition to producing insulin and glucagon. True or false? The esophagus temporarily holds the food. This is false. That's the stomach. So as we're doing our assessment, the objective of the history is to identify the client's specific problem and its possible cause. The history is going to include the client's chief complaint. A focus assessment of current nutritional, metabolic, and elimination patterns are important, along with their past history. The focus would be on any abdominal pain, issues with digestion, nausea or vomiting, constipation or diarrhea, incontinence, or any other complaints. Determine the client's use of tobacco or alcohol and any adverse reactions they may have to specific foods or drinks. As we're doing the physical assessment, it's important to look at their general appearance, look at their skin. Is there anything abnormal in the color? Are there any scars? What do the mucous membranes look like? We look at their mouth. Do you see any sores or lesions? What is their tooth condition? Do they have missing teeth? Do they have dentures? And if they have dentures, how do they fit? This could be a big cause of malnutrition if a client does not have the teeth to chew their food, or they have dentures that don't fit because it can cause their gums to be so sore that they can't chew. We're also going to assess the abdomen with the client in a supine position. Bend the knees slightly. That will help relax those abdominal muscles. We observe the shape of the abdomen and auscultate. Remember, always auscultate first. ABC. Auscultate comes before palpation. Then we would palpate. Nurses, our LPNs do not percuss. If the client has abdominal distension, let's say from ascites or some other issue, it may be necessary to measure the client's abdomen. And to do that, we need to mark where we are placing the tape measure with a permanent marker to make sure that we're measuring in pretty much the same area every time. We also may need to assess the anus for hemorrhoids or skin tags or fissures. We also need to assess the skin integrity of the anal area and stool characteristics. Different tests that we may do would include x-rays. This is going to help identify location, structural appearance of the organs in the abdomen, the chest, or the gastrointestinal system. We can use radiopaque contrast uh, and or a fluoroscopy to actually see how things move through the GI tract. We can do this with a barium swallow also, or an upper gastrointestinal series. So when we're doing the fluoroscopic observation, usually it is going to involve movement of things through the system. Again, it can help identify structural abnormalities of the esophagus, swallowing issues, and oral aspiration. Pre-procedural, they will be on a low residue diet, laxative, and they should not be smoking. Post-procedural, they need to drink a lot of fluids and potentially obtain some stool specimens. May require a laxative if the material has a tendency to cause some constipation. A small bowel series would be a fluoroscopy of the small intestine to identify obstruction in the jejunum or ileum, or potentially from a tumor or inflammation. Enteroclysis would be a small bowel enema. A barium enema or lower gastrointestinal series would help identify any polyps, tumors, inflammation, strictures, and abnormalities in the colon. Also helps us observe the rectum, the sigmoid colon, and the descending colon fluoroscopically. This would require the client to do some position changes. You know, when we do enemas, then they're always going to be on their left side because of the descending colon. You know, we want it to go as far up as possible. But this will also, position changes will help retain that instilled barium. And again, we may get stool specimens. May be necessary to do some dietary restrictions prior to the procedure to help reduce the formation of stool and or remove any residual stool. We can do an oral cholecystography or gallbladder series to identify stones in the gallbladder, the common bile duct, tumors that might be present, the ability to store a dye-like iodine-based radiopaque contrast medium. The x-ray should be performed before any other GI exam. These clients may ingest a dye tablet and then no eating or drinking, or they may be instructed to eat a fatty meal to see how the gallbladder reacts. A cholangiography is going to determine the patency of the ducts from the liver and the gallbladder. It will be used to determine if the gallbladder is not really visible, and we do know that it can be very beneficial in helping detect issues with the gallbladder and the bile duct. That would include the ERCP, the intraoperative cholangiography, the MRCP, and the PTC. We can also do radionuclide imaging to detect lesions of the liver or the pancreas and assist in how that gastric emptying is occurring with the use of injected IV or oral uh, dyes. CT scans are going to also detect structural abnormalities of the GI tract and any metastatic lesions. A hollow GI organs, we may use that oral barium sulfate or IV calcium phosphate. And before the test is done, we have to cleanse the bowel. The non-radiographic studies may include the MRI, using that magnetic energy rather than radiation. And this will examine GI structures, and again, oral contrast agents might be used. We can also do the magnetic resonance elastography or an MRI with a low frequency sound wave. We can do ultrasounds, which use those high frequency sound waves to help detect the size and location of the organs. It really provides a pretty good picture of structures, any abnormalities, maybe even cholelithiasis or pyloric stenosis, or changes in the appendix. A percutaneous liver biopsy would obtain liver tissue so it can be examined microscopically. It can also detect malignant changes, infectious or inflammatory processes, liver damage, or signs of rejection in clients that have had a liver transplant. These clients will need to lie on their right side post procedure for 2 hours. Then they do need to remain in bed for another 8 to 12 hours. The liver is highly vascular, and the risk for bleeding is going to be very high. So we need to monitor vital signs and monitor the biopsy site for bleeding, swelling, or a hematoma, in addition to monitoring breath sounds. Think about this. We are poking a needle in the liver, and what is very close to the liver other than the gallbladder? It's the lungs. So the risk of a potential accidental pneumothorax is always there. That's why we have to monitor those breath sounds. We can also do those endoscopies, which will provide a visual examination of the GI tract. And it can go down pretty far into the small intestine. If we do the colonoscopy, then it goes pretty much all the way through the large intestine, just into the small intestine. And of course, there are several lab tests that can be done, such as the CBC, urinalysis, urinalysis, serum bilirubin, cholesterol levels, serum ammonia levels, prothrombin time, protein electrophoresis, and enzyme levels. We can also look at different tumor markers in the blood studies. We can do an analysis with the upper endoscopy for the H. pylori, the Helicobacter. We can also do hydrogen breath testing and analysis of feces. True or false? An upper gastrointestinal series identifies structural abnormalities of the esophagus, swallowing dysfunction, and oral aspiration. True. After a liver biopsy, how many hours should a patient stay in bed? 8 to 12 hours.